Let's go ahead and get started. Welcome to the Department of Medicine Town Hall focusing on coronavirus. Tonight, we're going to talk about all the new therapeutic approaches that are being published both in the lay and scientific literature, and how to integrate them in terms of comprehensive care for our patients as we begin to assimilate this new knowledge and integrate it into a logical approach to patient care. So tonight we have two of our faculty members from the Division of Infectious Diseases, Lakshmi Chauhan and Steve Johnson. And I think Steve is going to go first, and then Lakshmi will follow. And we'll have plenty of time for discussion. So put your questions in the chat box for now, and I may call on you to ask your questions individually, depending on how many people join the call. Steve?
Yeah, thank you. First of all, thank you for inviting Lakshmi and I to talk about this subject. I will start out with a little bit of an introduction and a review of kind of the current standard of care. And then I will focus on some of the anti-inflammatory approaches to treatment, investigational. And then Lakshmi will talk about antiviral therapies and also talk about anticoagulation. And of course, we'll leave plenty of time for discussion. So just two slides actually as an introduction. This slide, I'm sure many of you have seen versions of this, the clinical course of SARS-CoV-2 infection, where pointing out kind of the important components with an initial burst of viral replication followed by the host inflammatory response. And so our therapies are really targeted at these two areas. Antiviral therapy, antibody therapy, which probably is acting mostly as an antiviral, seem to be more important earlier in the course of disease. And then immune-based therapies and anti-inflammatory approaches are more important subsequent to the disease. And of course, vaccines are important for prevention. I think it's important to understand this because in the literature, some of the studies that have not found benefit have really maybe looked at therapies at a time period in the course of this disease where they wouldn't be effective. And maybe an example that was presented last week with the antibody therapies, where some of the therapies in hospitalized patients looked less impressive than some of the outpatient prevention and treatment of milder disease. Another way to kind of think about treatment options is to put them into these three categories. What do we have for prevention? What do we have for outpatient management? What do we have for inpatient management? And then divide those into current standard of care and investigational therapies. Certainly under prevention, these two vaccines that are still technically not FDA approved, I think have become the standard of care. We learned today that the Johnson & Johnson vaccine, that they've applied for an emergency use authorization. So there may be a third vaccine that joins these categories. And then in terms of investigational therapies for prevention, there are a host of vaccines that are under study. The monoclonal antibodies and convalescent plasma that we discussed last week with David Beckham, and then antiviral therapies. And these therapies can be used as pre-exposure or post-exposure prophylaxis. In terms of outpatient management, the current standard of care is really supportive care, but we do have two EUAs for monoclonal antibodies that can be administered to individuals that have higher risk of progression to more severe disease. And then convalescent plasma, antiviral therapies, and immune-based therapies are being studied. The inpatient management, the standard of care now is remdesivir and dexamethasone. There is an emergency use authorization for baricitinib, also for convalescent plasma. And these other studies, other types of therapies are being studied. And of course, anticoagulation is a separate topic that Lakshmi will discuss. So let's review briefly the current standard of care. I couldn't resist putting in a slide about where we are with the vaccine, since there are at least 6, maybe 7 vaccines that have shown efficacy in clinical trials. Some of these have been published. Some of these are still as a press release, but really a remarkable story, the development of these vaccines over such a short period of time. So in terms of the treatment of COVID-19, I've taken one of the figures from the NIH guidelines and cut it into 2 over the next 2 slides, just to make a few points. So people who are not hospitalized with mild to moderate COVID-19, there are currently no approved therapies. This is an area of active study, of course, and I'll talk about this in a moment. As I mentioned before, there are these monoclonal antibodies available for outpatients who are at higher risk of disease progression. I wanted to mention that dexamethasone should not be used in this setting. I was actually on a call with some representatives from the FDA who have looked at prescribing patterns in the United States, and there appears to be a widespread use of dexamethasone in outpatient settings, and there are concerns about this from a toxicity standpoint. In terms of individuals who are hospitalized but do not require supplemental oxygen, dexamethasone should not be used. If you remember from the recovery trial, there was actually a trend towards harm in individuals that were not on oxygen therapy. There are actually insufficient data to recommend either for or against the use of remdesivir. We were part of one of the studies under the leadership of Tom Campbell, looking at the treatment of mild to moderate disease. There was a modest benefit at best. But I do think that we're looking to use these therapies in subsets of patients who are immunocompromised, feeling that there may be benefit in that setting, even though we don't have data to back it up. Now, moving to individuals who are hospitalized and require supplemental oxygen, but not yet on high flow devices, not yet on the ventilator. This is where we have really used as a standard the combination of dexamethasone plus remdesivir. The NIH guidelines give you a little latitude on either side of that, but I would say our standard of care has been to use both in combination. And then those who require high flow device or non-invasive ventilation, dexamethasone is really the primary agent here, although remdesivir can be considered. And then, of course, in patients on mechanical ventilation, dexamethasone reduced my mortality by 1/3 in the recovery trial. So just to kind of picture this in another way, this is just looking at the clinical status of patients and looking the sweet spot for remdesivir is people who are hospitalized and require supplemental oxygen. And then the indication for dexamethasone is a bit broader, including people on mechanical ventilation. So with that background, let's move and talk about investigational treatments. And you can divide these, of course, into antiviral and antibody therapies and immune-based therapies. As you can see, you can possibly strike through some of these compounds already, given some of the studies that have been done. Again, the recovery trial was a very important platform to evaluate these antiviral therapies. And then there's a host of immune-based therapies as listed on this slide. So we'll start with colchicine. Colchicine is an oral, relatively inexpensive anti-inflammatory drug that's used for gout. There's some data in heart disease as well. And there was a large study that was recently published in preprint form called the Col-Corona study that looked at the efficacy of colchicine in outpatients with COVID-19. This was a randomized double-blind trial in outpatients with either confirmed or suspected COVID-19. This was a contactless protocol. In other words, it was all done by phone and online. The subset of people who were eligible for this study were people that were over age 50 with at least one comorbidity, and it's the typical comorbidities you think about, or age greater than 70 in and of itself could qualify. And the colchicine was prescribed 0.5 milligrams twice daily for 3 days, and then daily for 27 days, and compared to 30 days of placebo. You might ask why it was such a long course of therapy. We actually had an opportunity on the guidelines committee to interview the Call Corona investigators yesterday, and they really stood up this study in March, right at the beginning of the epidemic. And at that time, they really had no idea about kind of the time course of COVID-19 and how long an anti-inflammatory therapy might need to be given. The primary endpoint from the study was the composite of hospitalization for COVID-19 or death, and there were over 4,000 patients enrolled. And this is the primary endpoint for the intention to treat population. At the top here, you can see the difference in the primary endpoint between colchicine and placebo with an odds ratio of 0.79 with a p-value of 0.08. It turned out in the study that about 300 patients did not have PCR confirmed infection. And so when they just analyzed the subset with PCR confirmed infection, they were able to see a difference as listed here that was statistically significant. There are a few other small studies that have been published on colchicine. Colchicine is actually another arm in the recovery trial. So it's not clear that this is quite ready for prime time, but it kind of fits the bill as an oral agent that could be used on an outpatient basis. Another drug with anti-inflammatory properties is fluvoxamine. Fluvoxamine is an SSRI, and it is a sigma-1 receptor agonist, which is a pathway that can reduce inflammation. There's an immunologist on the town hall that can maybe explain this in better detail than an infectious disease clinician. This had been previously studied in sepsis. And there are two studies of note here. One was published in JAMA. This was a randomized double-blind trial of 152 non-hospitalized patients with COVID-19. And they looked at clinical deterioration defined with these parameters here as listed in the slide. And deterioration occurred in 0% in the fluvoxamine group versus 8% in the placebo group with a statistical significance. And then the second study took advantage of an outbreak of COVID-19 in a congregate living situation at a horse racing track. And I use the term quasi-randomized study because people were really told about the availability of fluvoxamine and could decide whether to take it or not. So it was not a truly randomized approach. But hospitalization for COVID-19 subsequently occurred in 0% of those that received fluvoxamine and 12.5% who were just observed. This is now being followed by a phase 3 trial, which hopefully will have enough power to look at this as a potentially, again, outpatient anti-inflammatory approach. One of the, I think, most difficult sets of literature to understand in COVID-19 is the data on IL-6 inhibitors. There have been many studies, some of them with positive results, some of them with negative results. We were part of the study here with sarilumab, again with Tom Campbell as the PI. But there is a very recent study that has been reported, the REMAP-CAP study, which seems to show benefit of using the IL-6 inhibitors. In this study, most of the patients received tocilizumab, a smaller number received sarilumab. So this was enrolling adult patients with COVID-19 within 24 hours of commencing organ support in an intensive care unit were randomized to receive either one of these IL-6 inhibitors or standard of care. The outcome was an ordinal scale combining in-hospital mortality and then days free of organ support. And as you can see, most of the patients actually received tocilizumab. And the median organ support free days were actually 10 days for tocilizumab, 11 days for sarilumab, and 0 days for control. And you can see there was also hospital mortality was 28% for tocilizumab, 22% for sarilumab, and 35.8% for control. These sound like high mortality rates, but to remind you, these are people kind of en route to the intensive care unit. So it's really a subset of hospitalized patients. As mentioned, this is one of many studies of IL-6 inhibitors, some with positive results, some with negative results. But this was really a large, actually well-designed trial. So this trial actually led the guidelines committee to release a statement yesterday about the use of IL-6 inhibitors, saying overall there are insufficient data, but in view of the results from this REMAP CAP trial, some panel members would administer a dose of tocilizumab in addition to dexamethasone to patients who meet these study criteria and are also exhibiting rapid progression of respiratory failure. So really falling short of kind of recommending it as a standard of care, but really providing the option to consider that. The other anti-inflammatory treatment I want to talk about is baricitinib. This is a Janus kinase inhibitor. These inhibitors are already approved for the treatment of a variety of conditions, including rheumatoid arthritis and the other conditions that are listed on the slide. The kinase inhibitors are proposed as treatment for COVID-19 because they can interfere with processes that lead to immune activation and inflammation. And so primarily an anti-inflammatory approach, but the literature on baricitinib states that it also has possible antiviral activity through interference with viral endocytosis. So if you remember, the ACT-1 trial was the placebo-controlled trial that compared remdesivir to standard of care, and was probably the major study that led to the FDA approval of remdesivir. So the next iteration was ACT-2, and in this study, it was remdesivir IV with placebo versus remdesivir IV with oral baricitinib for up to 14 days. The primary outcome in this trial was time to recovery by day 29, and the day of recovery was defined as the first day on which the subject satisfied one of the following three categories as listed on the slide. And in the published report in the New England Journal on December 11th, study investigators noted an approximately 1 day reduction in median recovery time for the overall population treated with the combination of remdesivir and baricitinib versus those on remdesivir alone, and this finding was statistically significant. I should mention actually that some of our colleagues at Denver Health Medical Center are part of the ACT trials. And this led to the availability of baricitinib under an emergency use authorization, but I think it has seldom been used. And in fact, last time I checked with our ID pharmacist, it had not been used at all. And part of that is that we really don't know how this fits in with our other major anti-inflammatory approach, dexamethasone. Can this be used in place of dexamethasone, or as some studies have done, used both agents together? So I think this will be answered by yet another ACT trial, ACT-4, which is ongoing, started in about 2.5 months ago, where subjects are randomized to either remdesivir with dexamethasone versus remdesivir with baricitinib. And I think the results of this trial will probably help to establish the role of this. So that's all I had to talk about with anti-inflammatory compounds. So I'd like to stop my share and then turn it over to Dr. Chauhan to continue.
Lakshmi, let me know if you need any help.
Okay, I'll start the screen share now.
Good.
Okay. Okay, so thank you, Steve, for giving that primer on anti-inflammatory, which has been pretty confusing topic all this time. And I will go on to anticoagulation. Okay. Okay. So COVID-19 and thrombosis, this has been a topic of discussion since the beginning, when we started seeing all these patients presenting with various manifestations of thrombosis. And just thinking about the virtuous triad, there are some factors which are probably common to multiple other serious medical conditions, but I was looking to find if there were any particular things associated with COVID. And there are a few things which have been talked about in the literature, for example, endothelitis due to ACE receptor binding. The viremia itself can cause endothelial dysfunction. And there is also some talk about elevated levels of neutrophil extracellular traps. And I don't know too much about these mechanisms, but these have been mostly associated in bacterial infections, but they have found increased levels in COVID-19 infection as well. So just the same thing in a diagrammatic form. And microthrombosis now has been talked about as a major factor determining COVID-19 related organ dysfunction, morbidity, and mortality. And in one of a big meta-analysis with about 42 studies and 8,000 patients, they found that the odds of mortality was about 74% higher in patients who develop thromboembolism compared to those who do not. So I did dig deep a little bit into the literature to find the prevalence of thrombosis and COVID-19, and to see if it was really different between COVID-19 or other patients, and if there are any hematologists in the group or critical care people. I would love their input later on. But this is what I found based on NIH guidelines and everything else, multiple studies. So coming to the more obvious one, the hospitalized non-ICU patients, the incidence seems to range anywhere from 3.1 to 8%. And in non-COVID-19 patients, it seems to be in a similar range. In hospitalized critically ill patients, the range is quite wide, again, anywhere from 15% to 31%. We had a study published from UCH by Dr. Hippensteel and Dr. Burnham, and they found a rate of 26.1% in our critically ill patients. And looking at some of the literature, it doesn't seem that it is completely out of range for other critically ill patients, especially those who present with sepsis. We have all seen multiple arterial thromboembolic phenomenon after or during COVID-19. So I was curious to see what was the rate, but it seems to be about 2 to 5% in critically ill patients. There was a big study from Spain which showed a rate of arterial thromboembolism of about 1%. So it doesn't seem to be really as high as I had expected initially. And there was this one study from France in all outpatients who were not admitted and who presented for a CTPE. So it is already a skewed population, and there was 18% risk of PE in those patients. But I don't think this is any estimate of the incidence, because it just took a small group of patients. And I found this study on the other side of patients in Netherlands, which kind of follow these patients in the floor and in the ICU to assess the risk of thrombosis with respect to the number of days. And it seems like the cumulative risk increases over the first 20 days, and then it plateaus both in the ICU and floor patients. And it seems, and as expected, much higher in ICU patients than floor patients. And this was one of the initial studies which came about and caused a lot of discussion. I remember as a preprint in May when we were dealing with all of these ICU patients, and maybe one of the first ones where they showed a decrease in mortality, especially in mechanically ventilated patients who had therapeutic anticoagulation. And this was a retrospective cohort from New York City with over 2,000 patients, and the therapeutic anticoagulation showed increased survival, and the major bleeding risk was slightly higher, but still the benefits seemed to outweigh the risk. Of course, this was a retrospective cohort, but it did prompt a little bit rethinking of the anticoagulation guidelines and more use of therapeutic anticoagulation and higher dose of prophylactic anticoagulation. So this is where the NIH guidelines is on antithrombotic therapy. So for non-hospitalized patients, no anticoagulants or antiplatelet therapy is recommended. For hospitalized patients, prophylactic dose anticoagulation is recommended and no therapy to prevent arterial thrombosis. And there is still no data to recommend thrombolytics or higher dose or prophylactic dose of anticoagulation. And they suggest that when imaging is not possible and there is a high suspicion for thromboembolic disease, then we can give therapeutic doses of anticoagulation. And after discharge, a VTE prophylaxis is not recommended. And they give a small caveat in that one, suggesting that post-discharge it can be considered in patients with a modified improved VTE risk score. So this risk score incorporates age, cancer, history of thrombophilia, and a few other risk factors. And if they have a higher risk score, they could be considered for post-discharge VTE prophylaxis. And this is the UCH anticoagulation protocol, both for floor and ICU patients. And we have classified it a little bit based on the D-dimer. And I just wanted to point this out in the context of the study that we'll be discussing and what value D-dimer showed in that study. So for patients with low D-dimer, we are just recommending prophylactic anticoagulation, dose of enoxaparin, and in ICU patients, we are actually recommending a slightly higher dose than usual of prophylactic anticoagulation, which is also weight-based. So these are the two news statements and news releases which came in the last month and a half. So the first one was on December 22nd, which says that the NIH active trial of blood thinners has paused enrollment in the critically ill COVID-19 patients. And more recently, this news article came out which said that the full dose blood thinners decrease the need for life support and improved outcome in hospitalized COVID-19 patients. So I just wanted to talk more about these two trials, not these two, just one trial. It was a big trial with multiple groups involved. So this was a multi-platform randomized control trial involving 3 big groups, the ATT-ACC, which has multiple sites in Canada, USA, Brazil, and Mexico. The REMAP-CAP, which is again another randomized multifactorial adaptive platform trial in multiple different countries with 290 sites. And then of course, Active-4A, which has sites in USA and Spain. So this was a randomized open label adaptive trial. And the patients who were included were patients admitted for signs and symptoms of COVID-19, and they had to be randomized within 72 hours of admission. The intervention was therapeutic low molecular weight heparin or unfractionated heparin with a control of usual care pharmacological VTE prophylaxis. And the duration of therapy was either 14 days or hospital discharge. The primary outcome was an ordinal scale combination of in-hospital mortality and organ support-free days up to day 21. And if somebody died, they were assigned a value of -1. And some of the secondary outcomes were safety, which is major hemorrhage and HIT, and efficacy like mortality, intubation, major thrombosis, etc. Patients were stratified into 2 groups, severe or critically ill and moderate. And the moderate patients were further subdivided into high D-dimer, low D-dimer, or unknown D-dimer. So this is all interim data, which we could I could just find with the help of Dr. Johnson from the REMAC CAT side. It doesn't even show up on the active side at this point. And DSMB did the interim analysis on January 21. And as you can see here, there were about 2,800 patients randomized between the two groups. And the organ, the OSFT or the, I'm forgetting the thing, but organ, I have to go back, sorry. Organ support free days. The organ support free days was the patients with known organ support free days were 2,200. The patients were distributed between different age groups, but as expected, mostly between 50 to 70, mostly males. So this is all preprint data, and this was the primary outcome. So in patients who were in a moderate state, irrespective of the D-dimer, the proportional odds ratio was in the range of 1.5 to 1.57, showing superiority. But anyone who was in a severe state, it was up to 0.76, suggesting futility. So this is a more representative diagram of those patients, and the patients are classified from based on the number of days, and that was considered as a -1 score, and then the others are the number of days and color-coded accordingly, from red being the worst to blue being a best outcome. And as we can see here, patients in the moderate group had about 25% risk of requiring organ support if they were on just a thromboprophylaxis, but 18% if they were on therapeutic anticoagulation. And similar results were noted across the different groups, irrespective of the D-dimer. And then the patients with severe disease, they did not note much of a difference, as you can see in this picture. So these are some more numbers on the secondary outcomes. The thrombotic risk was 1.9% in the therapeutic anticoagulation, and in the usual care group, it was 3.2%. The mortality was 5.7 versus 7.7 in the moderate risk group. The major bleeding, as expected, was a little higher in the therapeutic anticoagulation group at 1.6 versus 0.9 in the usual care prophylaxis group. In the severe group, we can see decrease in thrombotic events of 6.7 versus 11.8%. The bleeding was also proportionately higher, but they didn't see any mortality benefit in that group. It was about 35.3, slightly higher, in fact, than the usual care prophylaxis group. So the conclusion based on the study, again, this is all interim preprint, still waiting for the final publication. But the conclusion based on the study was that the therapeutic dose was superior to usual care thromboprophylaxis group with respect to organ support free days in each D-dimer subgroup. So irrespective of the D-dimer subgroup, it was beneficial, and the major bleeding rate was less than 2%. And patients in the severe state, the therapeutic heparin does not appear to improve organ support free days till day 21. And the probability that the therapeutic heparin is inferior is about 98.5%. The major bleeding events were also higher as predicted. So this is just a diagrammatic representation of all the anticoagulation which are in trials, and this is just to show the number of trials which are ongoing. Anything ranging from low molecular weight heparin to all newer drugs, aspirin, combination of aspirin, clopidogrel, dipyridamole, all kinds of different combination trials ongoing right now. And this is also just a very brief list of ongoing RCTs in antithrombotics. So we'll probably have a lot more information coming in the next few months. And they are doing RCTs for different groups of patients to answer all these other complicated questions, So outpatients, inpatients, and post-hospital discharge. So Active 4 also has 3 different platforms. Active 4A is for inpatients. Active 4B is answering the question in outpatients with prophylactic therapeutic apixaban, low-dose aspirin, and Active 4C is post-discharge. So this trial actually raises more questions than provides any answers. It does provide answers, but it does raise a lot of questions, and we can discuss about this later. So how does this anticoagulation study change clinical practice? Should we start therapeutic anticoagulation in every patient admitted to med-surg floor? Are we comfortable doing that? And what would we do if a patient decompensates and transfers to the ICU and we have no real evidence of thrombosis? Next, going on to a different topic, which is a little less exciting and not much to report. So antivirals seem the natural kind of therapeutic strategy for any viral disease. And there are different targets that we have talked about, including drugs which inhibit viral entry, to drugs which are fusion inhibitors, protease inhibitors, drugs which inhibit RNA-dependent RNA polymerase. And there are different targets which have been considered, and based on these targets, different drugs have been tried with not great results so far. So this is just a list of some of these different mechanisms and the drugs under those mechanisms. These drugs, camostat and nafamostat, again, I have to mention that very few of these drugs are actually approved in the US. So lopinavir, ritonavir, remdesivir, and ivermectin are the only drugs approved in the US. Of course, hydroxychloroquine. But camostat, nafamostat are the transmembrane protease inhibitors. Favipiravir had some initial results which came out from different countries, mainly China and Russia. But these were all small studies which showed some early viral clearance, but we don't have much more information. Ivermectin was showing up in a lot of literature in between, and people were using prophylactic ivermectin, but we don't have much data on it. And NIH, specifically in their guidelines, recommends that ivermectin not be used. And umifinovir is an anti-influenza drug, which has been tried in other countries. Again, these are small unblinded studies, and there is no known efficacy. Since favipiravir has been talked about a couple of times, I just wanted to show a couple of small studies from other countries. So there was this one study from China with 236 patients. It's a randomized open label trial, and it showed clinical recovery in patients with moderate disease was higher in the favipiravir group, again, not peer reviewed. There was another study in Russia, which again was an adaptive open label trial design. And the viral clearance, which they checked by PCR, was much lower, much faster in patients on favipiravir compared to those who received standard of care. And just because Steve mentioned the fluvoxamine, I found this article a long time ago in Nature, where they had done mapping of SARS-CoV-2 protein and the host proteins and tried to find different targets. And the sigma receptor showed up as one of the targets. And this was considered to be a way to find drugs useful for repurposing. Hopefully we'll have more luck in future. And this is where it kind of sums up, and it says how we have made amazing progress in vaccines, and our treatments are still lagging behind, especially in the arena of oral antivirals, which I think is definitely a need of having good antivirals. And we have other virologists on this call, and Eric probably can help me out a little bit more with that and say why we are not being as successful. So that's it from me, and I'll stop here.
Okay, that was great, Lakshmi and Steve. I really appreciate it. So let me just ask a question from the chat box first. And before I do that, I want to encourage everyone to put in questions or to just raise your hand or unmic yourself and ask the question. I think we're a small enough group where we can just have a conversation. But the first question is from John Douglas, and it relates to to vaccine prophylaxis. What about the use of anti-inflammatory agents like non-steroidals or antipyretic agents like acetaminophen prior to? Has the committee, the NIH committee, come out with any recommendation related to that? It appears to be somewhat confusing advice on the CDC website.
Yeah, I mean, the initial issue with kind of non-steroidal anti-inflammatory drugs were they safe or not, and that was kind of the initial concern that they might not be safe, and I think what was determined is that they actually are safe and they can be used if there are indications for their use, but in terms of as a treatment for COVID-19, I've not seen actually data that would support that.
Just in terms of the vaccine.
Oh, I'm sorry. Yeah, so yeah, I apologize. So, I mean, I think the data, about using anti-inflammatories ahead of time, I think there were some animal models that they raised concern that anti-inflammatory compounds could blunt the immune response. I'm not aware of human data, certainly human data with the COVID-19 vaccines. So, but
so Steve, there's actually a study, this is Dave Beckham, okay. There's actually a study in a pediatric, it was a relatively large study, but it was obviously in pediatrics, looking at these young kids when they get all these different vaccines, if there was an effect of kind of prophylactically giving like NSAIDs prior to the vaccines in terms of immune responses. And there was some hint in that study that there were there was a small decrease in some of the neutralizing antibody responses, but it wasn't clear that it was like significant. And so so that's kind of all the data we have in people. So the CDC has clearly recommended, number one, prophylactic use of Tylenol or NSAIDs is definitely not indicated. And if you do develop some symptoms or side effects, they recommend Tylenol or acetaminophen. It's not clear that NSAIDs or acetaminophen would dramatically, if taken, after the dose of the vaccine, would dramatically alter your immune response. But there is some concern that if you prophylax with NSAIDs, you could potentially alter the immune response.
Doesn't particularly make immunologic sense, does it, David?
Yeah, I agree. I mean, obviously these NSAIDs and Tylenol, we don't consider them immune suppressing agents, right? Otherwise we'd use them like in transplant and things like that, right? So, I think what the concern is that they would decrease some of that innate immune response that you need at the local site, and therefore decrease some trafficking of some of the antigen presenting cells and some of those events. But again, it's not clear that that has a significant effect on long-term immune responses. But I think just to be kind of safe, I think like Steve was saying, the recommendation is, if you do develop some symptoms, you can take some Tylenol. Actually, I did. I took some Tylenol with my COVID vaccine, and there's no evidence that that's going to dramatically change anything.
Thanks, David. John, did you have something you wanted to add to that?
No, that was really helpful, David. I think one of the questions that's come up is if someone has an indication for taking a pain med, is there any reason to stop it pre-vaccine based on that theory? It sounds like sort of who knows. That was the piece CDC really didn't address. And I'm sure there's just not any data.
No data that I know of at all, right?
Thank you.
Let me, Steve and Lakshmi, let me just ask this question because it kind of is sort of a perspective setting question, which is related to the adaptive design of these therapeutic trials. First of all, I'd like you to explain that to everyone, what an adaptive design actually means. And secondly, does it result in false negatives? Does it result in us ruling out a potentially beneficial therapy by moving on quickly to another study?
Lakshmi, did you want to, are you referring to kind of the anticoagulation study?
No, I'm not. Part of the, well, let me make it clear why I'm asking this question. It seems to me that there's been a huge amount of progress over the past year. And part of that progress is the ability to move through a number of potential therapeutic agents and discard a number of them as not being beneficial. And some of those agents have been discarded by reaching a threshold through this adaptive design and then moving to the next potential therapeutic agent. I guess the first question that I have is what is the adaptive design, and do we risk the potential of not identifying a potentially beneficial effect of any one of these agents that we decide are not therapeutically beneficial?
So this has been something we discussed at previously as well about these adaptive designs and how they're quickly moving through drugs. And with 400 patients, sometimes they say it is a futile and then move on to the next drug. Hopefully they're achieving enough, hopefully they're recruiting enough patients for a statistical significance and show that it's futile. I'm no expert in statistics, so if somebody else has some more information on is it statistically prudent or not, I'd like to hear from them as well.
Yeah, I'm not a clinical trialist either, so I'll let someone else kind of weigh in that kind of understands it. I do think that some of the agents that have been studied with this adaptive design have also been in other studies as well, and some of the findings from these other studies are concordant. So it's, for example, it's not just one study that has determined that hydroxychloroquine is not beneficial and so on. So I don't know. It's is there a clinical trialist on the call that could weigh in on it? But
Michelle, do you know anything about these adaptive designs and whether they risk passing over agents that are potentially beneficial? So, let's move on to a more specific question. So what about the Brazilian trial of ivermectin? It seems promising. Anyone want to make comments about that?
yeah, I'll comment about that. It turns out that ivermectin is the #1 searched item on the NIH guidelines. And there are actually a number of trials, and the guidelines committee came out with a recent statement recently about ivermectin, kind of moving it from should not be used to insufficient data. There are some interesting studies supporting its use, including the trial in Brazil. I'd encourage you to kind of look at the kind of critical review that's part of the guidelines. There's a way you can click on the table and kind of go through each of the studies. But the bottom line is there are kind of significant limitations with many of the studies that have been reported. And we don't have that kind of definitive trial like we have with the agents that we currently use. There isn't, for example, a recovery trial or a NIH trial, that we have with dexamethasone and remdesivir. I mean, ivermectin has, in vitro activity against SARS-CoV-2. It's an inexpensive drug that's widely used for other purposes, but again, I just don't think it's reached, there hasn't been a study that has kind of clearly showed benefit, a study that's been well designed. Guess I'll leave it at that. But I'd encourage you to look at the section because it's been a major topic in the guidelines. And in fact, we even had a group that advocates for ivermectin use present to the committee and present their data and so on. So there's been a lot of time spent on kind of reviewing the literature.
So tell us a little bit more about your work on the Guidelines Committee. The Guidelines Committee has been really helpful in lots of ways because you're weighing the evidence and pointing us in the right direction. And I must say the website at the NIH is also incredibly clear about what should be done and what shouldn't be done in various patient subsets. I've looked at that several times and it's dynamic, it changes, it responds to new literature in real time, which is great. Maybe you can make some general comments about your participation in the Guidelines Committee, but also I'd like to hear specifically, have you identified areas that need further investigation and warrant more aggressive intervention trials? Tell us a little bit about that.
Well, first of all, it's kind of a lucky circumstance that I'm on the guidelines. I can think of, a bunch of people here at our university that could be part of the Guidelines Committee. It just so happened that because I was involved with the HIV Guidelines Committee, and they needed to stand up a guidelines panel very quickly in March, that some of us who were on the HIV guidelines panel could be part of this. I should mention that Steve Cantrell, who's emergency medicine from Denver Health, is also on the Guidelines Committee from Colorado. And it's a bit different than some of the other guidelines because there are pulmonologists and critical care specialists, they're hematologists. So the guidelines about anticoagulation include people that are part of the Thrombosis Society and so on. So and there's pediatrics and OBGYN, and there's representatives from all the different medical parts of the government, like the FDA, DOD, and so on. I think a current emphasis is beefing up the section on outpatient management, because I think that's an area of the guidelines that had been kind of underrepresented, and especially with some of this information about outpatient dexamethasone use and azithromycin and some of these other kind of therapies that were really being widely prescribed in the absence of clinical data. So that's been an area of emphasis. But it's mostly been, very interesting. Yesterday we had the folks from Lilly present their data, some of it confidential, about the monoclonal antibodies. Yesterday we had the Call Corona investigators talk about colchicine, and we had the recovery people come and talk about things. So it's actually been an opportunity. It's one of those things that you may learn more than you contribute.
I'm sure you're contributing plenty, but it sounds like an enjoyable process. One of the surprising things for me is dexamethasone in outpatients, symptomatic. So individuals with mild disease, and I've actually interacted with probably 3 or 4 dozen patients with outpatients with mild disease, asking me for, what should they do, asking me for advice at various stages. And I'm impressed that all of them seem to go through an inflammatory phase. The ones that are symptomatic, that is. And so the question that I'm wondering about is, has the right trial been done with dexamethasone in outpatients, or can we definitively say that steroids don't work in outpatients?
No, I don't think the right trial has been done. I mean, I think the concern for outpatient medicine is extrapolating primarily from the recovery trial, because the recovery trial had a group that were hospitalized and not on oxygen, and there was actually a trend towards harm. So I think there was this, thought that if it's harmful in hospitalized patients that don't require oxygen, that it's probably harmful in the outpatient setting. But I think the outpatient setting is a pretty diverse group of individuals, and so you might have individuals that have an inflammatory phase. And a couple of the things that I presented tonight, the colchicine and the fluvoxamine, if they turn out to be effective, they will be anti-inflammatories, but maybe with not the same risk potential of dexamethasone. I don't know if anyone else has thoughts, but.
Lakshmi, you mentioned the difference in the investment in vaccines versus the investment in therapeutic agents and trials. My view is both have been very successful in identifying therapeutic agents that work and those that don't work, which is equally important, and also developing a number of vaccines. What would you say, in retrospect, should have been the balance in investments? I think we were quite fortunate in coming up with so many vaccines. It's certainly possible a year into it, we wouldn't have had any vaccines. And if we didn't, the therapeutics would have been that much more important. What are your thoughts?
I think therapeutics we have done very good trials on therapeutics and know a lot of things which don't work. We started with hydroxychloroquine, and the dexamethasone probably was the big therapeutic advance that we have had. My main point was with the oral, or rather not oral, but antiviral therapeutics, which I think at this point we have remdesivir, but we don't have too many other antivirals, and oral antivirals would be really helpful in those patients who are outpatients, just mild symptomatic, and could potentially turn the curve of our hospital admission. So it would be nice to see some more movement in that. And it could be a lacuna in just how we can develop. We have not had very good oral antivirals for other viruses for different reasons. So maybe just something which is difficult. But it would be nice to see some more drugs coming out in that arena as well, which will make it easier to treat outpatients who are symptomatic and maybe prevent progression. So, vaccines, of course, have been excellent, and hopefully will be the hope as we go along.
Okay, this has been a really great discussion. Any closing comments, Steve or Lakshmi, that you'd like to make?
No, I don't think so, but I think some of the things that we've talked about tonight, the anti-inflammatories, it'll be very interesting to see kind of what the ultimate outcome is with colchicine, especially since you have a really large kind of trial and you're talking about an oral medication that could be a game changer. And I think Lakshmi's discussion about anticoagulation, I mean, that's really kind of the decision that has to be made now, is whether we shift gears and are more aggressive with anticoagulation on the inpatient side.
But not in ICU patients.
But not in
Not
ICU
ICU
patients.
Yeah, we've also, I think we've all seen complications of anticoagulation in ICU patients with coronavirus.
The guidelines will address the anticoagulation issue. I think kind of waiting for these studies to be published so that more of the kind of details are known. As Lakshmi mentioned, right now they're kind of mostly press releases and things like that.
Yeah. Okay, well, thank you very much. We're getting a lot of comments here that this was a terrific update, and it has been a terrific update. Appreciate it. And I'm sure that there are going to be a number of other breakthroughs in terms of treatment for individuals with SARS-CoV-2. So thanks a lot.
Thanks for having us.
Thank you.
Sure. Good night.